Time for the meeting has arrived. I'm going to recognize Chairman Goggins to open this proceedings with a prayer.
Thank you, Mr. Chairman. If you'll bow your head, please. Our most kind and gracious Heavenly Father, as we come to you this morning, Heavenly Father, first of all, we lift you up, and we want to say thank you for the many blessings of life. And Lord, we sit here this morning, and we're facing an economic crisis in this country where we have many job losses, Lord. We have many families hurting. Heavenly Father, as we gather together today to talk about health care, Heavenly Father, I pray that you would enable us all to work together. You would enable us to be able to have the wisdom and to be able to discern what we need to do. Heavenly Father, I just pray your blessings upon these proceedings today, and I pray for the panel here and everyone in this audience. Lord, I pray that your blessings will be upon each and every one. We ask all this in the name of your Son, Jesus Christ. Amen.
Thank you, Senator Goggins. This is the joint House-Senate Health Appropriations public hearing. We're here to take comment on the 2010 budget. The chair would like to request that you limit your comments to no more than 5 minutes. I know that's hard sometimes, but we have a lot of committee members as well as people in the audience who have a long way to drive today, and we will have to strictly enforce that. We'll have, when you have a minute left, we'll let you know that. And we appreciate everybody being here. Members of the committee, as you know, if you have a question at any time, press the button on your mic, and then I will certainly recognize you. Our first presenter is Jimmy Lewis.
Thank you, Mr. Chairman. My name is Jimmy Lewis. I'm CEO of Hometown Health, and we represent 55 rural hospitals. I come to you this morning feeling like I preaching to the choir. We thank you very much for the support. For the support that you've given to rural hospitals in the 09 budget, especially in the area of the private ICTF that you are so gracious as to pursue for us. I come to you this morning to present some information pertaining to rural hospitals, and I do it in rather cryptic, stoic fashion, but nevertheless it lays out some of the things that we feel are important. And with your permission, I'll just read down through these very rapidly. I just want to present to you facts. The facts about rural hospitals are, and this is a following list. You as legislators just saved many rural community hospitals with your private ICTF initiative. The state has no health care access plan. The state has no health care vision. Many rural hospitals have less than 10 days cash on hand. One rural hospital closed last year, Telfair Regional Hospital. 33 of 35 critical access hospitals have dropped OB. All 35 critical access hospitals are totally subsidy dependent, existing entirely on Indigent Care Trust Fund, upper payment limit, and county subsidy, with several subsidized over $1 million annually. County commissioners all over rural Georgia are scrambling to deal with hospital closures as they learn they will incur the liabilities upon closure. 2 mid-sized rural hospitals have recently dropped OB, bringing the total to 4 or 5 mid-sized that do not deliver to about 4 or 5. 2 small hospitals have had to have state assistance to make payroll in the last 4 to 5 months. As many as 5 smaller hospitals are totally subsidized by a regional hospital whose counties are now asking, why are we supporting out-of-county hospitals when we have to raise taxes to support them? Rural hospitals typically have 80% of their patients covered by governmental payments. The state implemented CMOs and gave no relief from EMTALA, which means that the state cut payments while forcing hospitals to see patients with no means of getting paid. Beginning in FY 1998, a change was made to pay 90% of cost to Medicaid, and then a reduction was made to 85.6% of cost in 04. And then in 06, DCH changed the way the interim outpatient rates were calculated, and it changed the cash flow, dropping that payment down another 4% to now cash flowing only 81.6% of cost. Hometown doesn't represent large hospitals, but we do know that virtually all large hospitals have been very dependent upon their dividends from their reserves, but just recently they were advised that they must recognize impaired assets on their P&Ls immediately, which will throw the whole large hospital scales back into chaos, which will then prevent rural hospitals from being able to transfer patients that exceed the licensure and liability capacity of the rural hospitals, with no means of getting paid on high-cost patients, thus killing the rural hospitals further. The federal government will be seeking major paybacks through a RACS program, Recovery Audit Contractors Program, that begins August the 1st. The federal government will convert into a new Medicare payer on May the 4th that will rival the ACS debacle as to cash flow disruption with the implementation of CAHABA. And you as legislators will have to go home and face the communities that will lose these rural hospitals if this is allowed to occur, as did occur in McRae. I tell you all this to say that the proposed governor's provider tax and his Medicaid rate cuts take none of this into consideration. Apparently none of the budget writers have an awareness about any of these issues, and yet the industry is facing these huge reimbursement cuts, and or now they are pressing again for provider taxes. What is the sense of these kind of cuts when the state does not seem to have drawn down all of the stimulus money, nor has it drawn down all of the federal drawdown money, and it specifically has directed Medicaid stimulus money to areas other than in Medicaid? With the proposed Medicaid cuts coming from the governor, Georgia can lose 20 of its critical access hospitals and 2 to 3 of the mid-sized rural hospitals. There is a report coming from the Office of Rural Health shortly that you must secure and read, and it will illustrate just how bad the rural hospital industry is. It's a commissioned report that's funded out of federal money. It's in the Office of Rural Health, and for some reason or other it's not available because it's in edits at the department. That would be a devastating report to see for rural hospitals because it will define how these hospitals can and will close. Now, given all of the above, we come to face a Medicaid budget that can lead to closing these 20 hospitals. That means 300,000 people will lose access to a hospital and will have to drive 20 to 60 miles for health care. That means Georgia will increase its already soaring unemployment by 3,000 people in communities where the hospital is one of the top 3 employers. Local rural communities will look like ghost towns as in Ashburn or Vienna and Sparta, and I'm from near all of those, so I can relate. Rural hospitals beg you to allocate all of the Medicaid stimulus money to Medicaid and as a minimum to look at the tobacco tax as an alternative funding source and help us save rural hospitals, rural communities, and tax-generating businesses. You as legislators are all that stand between the certain catastrophe that will occur if this is allowed to occur. The third page shows a payer mix analysis that illustrates for the PPS hospitals and the critical access hospitals how, with the current typical payer mix in a rural community, they lose money on every revenue dollar that they gain. And then in today's Atlanta paper, there is an illustration where the unemployment is the highest, and in the state of Georgia, the rural communities are absolutely devastated by that, and this will be compounded by these losses. Thank you very much for the opportunity to present to you.
Chairman Goggins has a question.
Yes, sir.
Ms. Lewis, thank you very much for all you do and for this you brought to us today. I'm going to ask you some questions real quickly. I know everyone's in a hurry. On 4, many rural hospitals have less than 10 days cash on hand. Do you know the number of those?
I would estimate that it's probably 6 to 8 currently, under 10. There's probably 6 to 8 that's close to 0. Less than 10 is probably 10 to 15.
Could you get me a list of those?
I'm sorry?
Could you get me a list
We
of
can
those?
work that out, yes.
Correct. How many of the county commissioners are subsidizing hospitals of yours?
Don't know the exact number, but it's probably about 50% of the hospitals in some form get some kind of subsidy. The other 50% don't.
Okay. And I wasn't aware of the payer mix and rule. Was 80% governmental payments?
The 80% governmental, when you take 40%, 50% in Medicare, 25% in Medicaid, and another 15 to 18% in self-pay, which ultimately is covered by the subsidies, it gets it to 80%.
Okay. What would it take for us to get this report you're talking about from Office of Rural Health?
I would expect the power of the legislature has significantly more power than that of a lobbyist.
All right. Thank you, Mr. Chairman.
David Tatum.
Thank you, Mr. Chairman. My name is David Tatum with Children's Healthcare of Atlanta, which is the entity formed by the merger of Eggleston Children's Hospital and Scottish Rite Children's Medical Center back in 1998. We also operate Hugh Spalding Children's Hospital in the Grady system, and in August of last year we acquired the Marcus Autism Center. What Daniel Thompson is passing out is a little fact sheet about Children's that I'd like to go over. Although we are Children's Healthcare of Atlanta, we're in Atlanta in name only. We serve 8 out of 10 pediatric Medicaid cases in the Atlanta area, but 4 out of 10 statewide. We have 510 beds in our system, more than 6,700 employees. We have 1,400 pediatric doctors on staff. Last year, we saw 553,000 pediatric visits. That's 262,000 individual patients. 170,000 of those came to the emergency department. We are the only place in the state, if you go to the second page, that you can get certain services. Particularly in cardiology, we do things that no one else does. Neurosurgery, the same thing. And in transplant. We also operate Sibley Heart Centers around the state. Our cardiology practices have an outreach, and Dr. Pat Frias with Sibley is here today. But in addition to Atlanta, we have locations of Sibley in Athens, Columbus, Gainesville, Macon, Albany, Canton, Cumming, Dalton, Decula, Sharpsburg, Tifton, and Villa Rica. The last couple of pages of that handout speak to the economic impact of Children's. We've actually contracted with Georgia Tech to ask them to run some of their analysis on the market impact and what we contribute to the state economy, and their preliminary findings are at the bottom of page 2. I would argue that Children's Healthcare of Atlanta has more economic impact than the Kia plant. With all that being said, however, we're the largest Medicaid provider in the state. About 55% of our kids are covered by the Medicaid program. At the Sibley Heart Center, in some of those locations that I enumerated, it is 90%. Our estimates and what we've heard from the governor's staff of what the cut would be, $80 million to hospitals, they've told us that's approximately 10%. A 10% cut to our Medicaid rate is a $30 million decrease to us. We would have to make some very difficult decisions on the number of employees we could keep employed and the number of services we could keep providing. And I assure you we would not be able to do the cardiology outreach work around the state that we're currently doing. We would also lose our bond rating. It would be gone, which means we wouldn't have access to capital to build and renovate and refurbish our facilities to keep pace with needs and the pediatric population growth in this state. I'm always asked when I make testimony, well, what's your idea to fix this? Well, I got two. One, federal medical assistance percentage to me is important because medical assistance means medical assistance. Some of y'all have been around long enough to remember that the Department of Community Health used to be called the Department of Medical Assistance. I believe that medical assistance money should go to medical assistance. If the Medicaid budget is filled by the federal FMAP money first, and all the needs are taken care of in that budget, if there's dollars that are left over, then perhaps you can consider moving it to other areas. But my understanding of the governor's budget proposal is that $526 million of that federal FMAP money has been moved to other areas, and I don't think that's the right move to make. Second, we endorse the tobacco tax that you'll probably hear some more about today. I've seen numbers that indicate that anywhere from $300 to $450 million could be generated by that. It has long-term positive health consequences, and it's something that is residing in the House right now and could theoretically be moved before crossover day. In any event, those are our recommendations. I'm reminded by the Hippocratic Oath, which doctors take, which say do no harm. And our request to y'all is do no harm to access to kids for the services they need covered by Medicaid in Georgia. Thank you.
Mr. Edelman, I have a question.
Yes, sir.
The governor's revised proposal, the $80 million cut, as you know, that's state dollars. It's, we think, somewhere around $260, $270 million total dollars. Your $30 million you're taking into account that if the governor's proposal is adopted, I assume you are taking into account the total amount.
Yes, that's correct, sir.
Okay, thank you.
Thank you.
Mr. Tatum, you come back. Representative Rinders has a question.
Thank you, Mr. Chairman. Can you tell me how much revenue you had over expenses last year?
I haven't seen the final 08 numbers, but I think it was in the neighborhood of $60 million.
$60 million?
Yes, sir.
Is that in a reserve account or?
No, we plow that back into the facility, and it's no secret we've had historically a fairly healthy foundation and endowment as well. But in the market, like most others, we've taken a pretty big hit. It's down about $500 million from this time last year.
So you've got $500 million in reserves, and you've made about $60 million over.
No, sir. We lost $500 million out of our foundation endowment.
So what's in your foundation endowment?
I think about $1 billion.
$1 billion.
But you can't just write a check off of that. That's contributions that are made for various purposes.
For what purposes?
Goes to particular programs at the hospital, but it doesn't go to a lot of it doesn't go to operational expenses, which is what we're talking about here.
But it's much like our reserve would be, I guess, huh?
With some limitations.
Okay, thank you.
Thank you.
Thanks.
Stephen Neff.
Morning, Mr. Chairman, members of the committee. Thank you for this opportunity to speak. My name is Stephen Neff. I have a one-pager going around, so I'll keep my comments brief. I come to you today representing the home and community-based providers of this state. That's the Assisted Living Association that I represent, the Georgia Association of Community Care Providers, and the Service Providers Association for Developmental Disabilities. I come to you today with what I would think would be a pretty easy request because you all have approved it prior, but we are asking you all to please reinstate our 3% provider rate increase that was approved prior by this House, by the House, by the Senate, and by the Governor's office. The history on those funds is we know in the economic downturn, those funds were rescinded and had to be taken back, then delayed. They were then placed in the 2010 budget by the Governor, but then have been removed again. We ask you to please support those rate increases moving forward. We also support all of the slots and services in this state for MRWP, CCSP, and ICWP. We support those for our rate increases as well. We support you all finding, if possible, any funding revenue solutions to fund our rates and for those slots. We, of course, support the tobacco tax as well, as it's going to be mentioned by many folks. We support the stimulus funding, whether that is the funding directly from the federal government, or if that is other state funds that are released due to the increase in the FMAP. We feel this is very important. This is a very much needed for our providers. Some of these providers haven't actually had rate increases in 12 years. Some in the last 4 years, others in the last 6 years. The assisted living group is very, very much unfunded. So we ask you to please support that. With that, I can tell you can see the cost there of what the 3% rate increase. It was in the governor's budget in 2010. With that, I'll be happy to try to answer any questions.
Don't have any questions. Thank you.
Thank you very much.
April Beckford.
Good morning, Chairman Chanel, Chairman Goggins, and members of the Joint Committee. My name is Avril Beckford, and I'm the chairperson of the American Academy of Pediatrics, and I come before you on behalf of 1,800 pediatrician members across the state of Georgia. I've practiced pediatrics for over 25 years and have spent the last 17 in my current practice in Smyrna and Austell. We come today to urge you to reconsider the proposal to reduce physician reimbursement rates in the 2010 DCH budget, as suggested a few days ago. Such cuts, if enacted by the General Assembly, would have a devastating effect on access to care for these children. It could potentially negatively impact access to care for all children, and at the end of the day, represent a poor business proposition for the state and for our taxpayers. Because nearly 70% of the patients in the Medicaid program are children, no provider group is more dramatically impacted by Medicaid reimbursement than pediatricians. In a recent poll of our members, nearly 55% reported that Medicaid and peach care patients comprise more than 40% of their patient volume. And nearly 1/3 reported that Medicaid patients were more than 60% of their practice. Pediatricians want to do the right thing, and they have. We chose pediatrics over other specialties in medicine because we have a special feeling for children, and we wanted to devote our medical careers to caring for them. But pediatric practices must be able to remain viable as economic entities, just like any other business. But because Medicaid rates have been frozen for 8 years, as Chart A in my handout will show you, many pediatricians are approaching what we call the tipping point on whether they will be able to continue seeing Medicaid children and remain in business. For pediatricians, this breaks down into two groups. There are those who can stop seeing Medicaid patients because Medicaid comprises but a portion of their practice, 5, 10, or 20%. Many of these physicians may simply conclude that it's not feasible to see these children and close their practice to them. However, these physicians still make up an important part of the capacity to serve those children, and that capacity will be missed. But the second group are pediatricians who, due to the poverty levels of their community, have such a large volume of Medicaid patients that leaving the program would be impossible. For them, the issue becomes one of sheer business viability, or putting plans to expand or add physicians on hold, or even relocating from their poor communities. None of these options is good for children or for the state's healthcare system. To reinforce this point, we noted that nearly 1 in 10 of our members said in a recent survey that they would consider closing their practice or having to retire if reimbursement rates were cut again this year. The proposal you have before you to now cut into current rates has the potential to push more practices to the brink. Nearly 60% of our members reported in the survey that they would reduce or have to stop seeing Medicaid patients. When a pediatrician in South Georgia decides to relocate to another larger city or to move to a different state, and this has happened to us, the whole community loses access to the care that the pediatrician was there to provide, not just the poor children. And then where do those children go who will get sick, because we can guarantee that? They go to the local emergency room, which is a wonderful asset to handle real emergencies for your child or for yourself, but is a very poor and very expensive way to deliver routine health care. Furthermore, flooding ERs with routine primary care cases can diminish the ER's capability to respond adequately to full-blown emergencies when they occur. In summary, pediatricians want to provide care for the children of our state, and we certainly believe that children should have access to care. This is not just a wonderful sentiment, it makes good economic sense. If these children do not have medical homes, that is, a physician who sees them regularly and provides for all aspects of their care, then these children will end up in the hospital ERs consuming the most expensive form of care. And who pays? The taxpayers, the businesses, and the whole community. We therefore urge you to find a better alternative than the current proposal. And we would also like to add our support to House Bill, to H.R. 39. It makes good economic sense, good business sense, and puts personal responsibility on those in terms of tobacco use. Thank you for your time.
Thank you.
Any questions?
Faith Brown.
Good morning, Mr. Chairman. I'm Faye Brown, and I'd like to cede my time to our Vice President, Dr. Harry Struthers.
Good morning. I'd like to thank both Chairman Goggins and Chairman Connell for allowing us to testify on the fiscal year 2010 budget as it relates to the Department of Community Health and Medicaid. This is not something that I usually do. I'm a family physician, and I see older patients, and so I'm a little bit nervous about it, but it's important to me, so I got some people to fill in for this morning. As Faye stated, I'm Vice President of the Georgia Academy of Family Physicians. I'm also Chairman of the Family Medicine Department at Morehouse School of Medicine. While I'm not teaching medical students or residents, I'm seeing patients, as I was yesterday afternoon and evening. The bulk of my patients are seniors, and I spent last evening actually at Crestview Nursing Home, admitting a new patient there. I concentrate on geriatric medicine. I'm the only geriatrician in the department right now. So almost all of my patients are insured either by Medicaid or Medicare or a combination of the two. The Georgia Academy of Family Physicians is a 2,500 member association comprised of family physicians, residents, and students. Our members have practices in virtually every corner of the state. We've heard about the governor's recommendation to cut Medicaid provider rates in the 2010 budget. This will be devastating to our safety net as well. It's devastating to our patients and will be devastating to the ability of me and my colleagues to continue to see Medicaid patients. We're somewhat in the same situation as Dr. Beckford was talking about. In lots of places, we're the only providers in the county. As you already know, Medicaid payments are well below what it costs to care for Medicaid patients. In July 2008, the Department of Community Health cut provider rates by 7%. This new and additional cut we've heard about could be between 6 and 10%. Will force many of my colleagues to abandon long-time patients because they'll be forced to drop Medicaid. In a survey that we sent out to our members, Georgia OBGYNs, pediatricians, internal medicine physicians, over 40% stated if there were additional Medicaid cuts, they will be forced to either drop Medicaid patients or close their patient panel to new Medicaid patients. In addition, many of my colleagues indicated with the current downturn in the economy, and most of them in the state are small businessmen and women, that they are either have reduced staff or considering reducing staff hours, laying off staff, and looking for other ways to reduce overhead to continue to meet their current patient load. Another Medicaid provider cut would be dire to the safety net of resources that we've had here in Georgia to take care of our constituents, your constituents and our patients. Family physicians take care of the entire family from the beginning of life, and we're being squeezed by the current economy that could force us to change our ability to take care of the entire family. Frequently, when parents lose their insurance, the kids get on Medicaid. And we've traditionally seen the whole family. And so it's real difficult to not see part of the family because of their insurance. This has been our model of care for over 60 years. Please recognize that a cut in state Medicaid spending is a triple cut, as every dollar from Medicaid equals 2 additional dollars from the federal government that will give the state to spend on Medicaid. Don't take stimulus funding to cover the Medicaid budget and use it for other state budget needs. Our health of our citizens in our state is more important than that. So cutting Medicaid is bad for business, bad for Georgia's economy, bad for overall health and welfare of our citizens. Like others, we support the increase of the fees on tobacco use. It's good clinical medicine. It's good for public health, and in this situation, it's good for economic reasons. So thank you for your attention, and I'll be glad to answer any questions you have.
Don't see any questions. Doctor, thank you for taking time out of your busy practice to come down here and share it with us.
Thank you.
John Howell.
Mr. Chairman, distinguished members of the committee, I'm John Howell with the Georgia Healthcare Association. Georgia Healthcare Association represents 95% of Georgia's 359 skilled nursing facilities. We also represent 99% of the source case manager providers in Georgia. The packet that Jason's handed to you now has 3 things in the folder. The first thing is a letter that we presented to the governor that has on page 2, we believe, 6 viable options within the long-term care sector to save money to be able to properly fund our program. The next thing is a PowerPoint slide that I'm going to spend the bulk of my time on today, and the last thing is an economic impact study. And we'll be happy to be a resource to the committee if you deem appropriate to explain further. But in the essence of keeping within the 5-minute time limit, I just wanted to provide those as a resource to you. And I'll skip around a little on the slides. If we could move to slide number 5. This is a pie chart that actually shows the current FMAP before the increase, because I think there's still some numbers to be looked at in the FMAP increase, whether it's going to go above the 6.2% due to unemployment numbers continuing to rise in Georgia. But this is an illustration of the providers that are in the Medicaid program. And you see the top chart shows 35.9% state funds, 64.1% being the federal match. Well, in 2003, the skilled nursing facilities entered into a self-imposed provider fee. And the next chart below shows that through the utilization of the nursing home provider fee, that only the state portion is only 24.5%, with the federal government and the providers making up the rest of the investment in the long-term care program in Georgia. The next slide shows you that illustration. We were spending $344 million in 2003 in state funds on the Medicaid program, and it looks like $261 million in 2009. So less state dollars going into nursing homes in 2009 than all the way back in 2000. The program is between the federal matching portion and the provider fee portion is $1.8 billion on the next slide. And I'm going to skip to the Medicaid days slide. In 2001, we've been making over the last decade, we've been making strategic changes to the skilled nursing facility model. This is not a place where you have just forgetful older folks being taken care of in nursing homes. These are extremely sick patients, high acuity patients, and you can see that the mix of our patient population has actually changed, and the percentage of Medicaid days is extremely high still. In 2001, it was 83% were being served under Medicaid, and there's been a steady progression to try and serve a Medicare patient, to rehab those patients and send them home. But you see, in 2007, we're still at 75%, over 75% of the patients we serve are on Medicaid. So we're one of the highest dependent, if not the most dependent, providers on Medicaid. If you'll skip one and go to the blue bar chart, that shows the CMI. That's the case mix index. That's an indication of how sick the patients are in our facilities. So we're taking less Medicaid, we're taking a higher acuity patient, a sicker patient, and we're serving the less sick patients in the community utilizing programs like the SOURCE program. This is something that the legislature and policymakers have asked us to do, and we've tried to be a part of that solution. The next slide shows Georgia's Medicaid rate in nursing homes compared to our southeastern neighbors. We're dead last, with states like Alabama and Mississippi having a higher rate in upwards of $20 per day per patient. And the next slide shows you a trend of what we anticipate in terms of the baby boomer generation. We've got to get some infrastructures in place because the baby boomer generation is demand a different product than what is currently being offered in skilled nursing facilities. And we've got to get geared up and ready for that. And the last slide is really the ask. And what we're trying to do is free up the FY 2009 dollars that the House and the Senate and the Governor signed. Free up those dollars to start our fair rental property system. Right now, our property is being reimbursed on a 1983 Dodge Construction Index. We're trying to modernize our buildings. This incentivizes the providers to do the right thing. You make investments in your building and you get reimbursed at a higher property rate. The other thing I'll bring to your attention is we're trying to get our audited allowable cost, the 2008 cost report. This is not an enhancement. This is what people spent. The Department of Audit goes through those numbers. We have ceilings and efficiencies in place, and all we're trying to do is get those dollars back for our providers. With that, I'll end the presentation. Any questions?
I don't see any questions. Thank you.
Mr. Chair.
Norma Adams.
Mr. Chairman, members of the committee, my name is Norma Adams. I'm with the Georgia Association of Homes and Services for Children. Thanks for this opportunity. I want to talk about the rate cuts across the board in the DCH budget. I want to offer a better solution. All of us are standing here. We would love to have the monies restored that the rate cuts reflect, but looking at the economy and what's going on, very little of that probably will be done. But let me talk to you about the rate cuts. The rate cuts does not reflect good public policy for the state nor for the providers. A rate cut essentially eliminates the sustainability of our providers to provide the services that the state of Georgia needs to provide it. This is not only in DCH, but is also DHR. If you were a Starbucks on the corner serving coffee, and you had the margins that most of our providers have, which are none, and the state came in and said, Starbucks, that cup of coffee, we want you to take anywhere from a 10 to a 15% cut, a cut on what you charge for that cup of coffee. And Starbucks had the margins we have, which are none. Starbucks would say, you want me to serve the same number of cups of coffee for less money. I'm not going to do it. And that's exactly what's happening with our providers. Our providers are looking at the proposed rate cuts, or some of the rate cuts have already happened, and saying, we cannot do it. By public policy, some of our providers are paid only cost. And now the state is asking our providers to take a rate cut. Let me give you an example. 2 years ago, the state came to our providers and say, look, we want to build a comprehensive community mental health network, and we need providers to do it. Right now, we're not covered in the state. 300 of our providers stepped forward and said, we think we can do it. 240 of them qualified to do it. When the rates came out, only 80 of our providers did it. Only 80 of our providers are now providing those services, even though 240 qualified to do it and went through all the approval process. Let me suggest a better way. A better way is not only look at the expenses, but also look at the income. I do a new provider orientation every month, and there's two sides of a budget, expenses and income. We've got to look at where our incomes are. Let me suggest that we look seriously at the tobacco tax as a source of income that will pay rich dividends, not only for the 300 additional millions of dollars that might come in, but also the reductions in smoking that particularly will happen with our younger people and also some adults. That will be some real savings, and that will be some income that we need to look at. But another thing that we can do, when you look at the budget and you see rate cut, change the language to this so there's a little bit more flexibility for the department and for our providers to provide the services that that Georgians need. Rather than rate cut, say something like this: reflect savings based on lower utilizations and efficiencies and higher efficiencies. That way the department can work with providers to figure out how can we serve the most needy people at the same rate, and also realize some efficiencies, maybe through some incentives, so that we can serve more people for less money. We know we can do that. We've seen it across the board in state government. But this type of language mandates the department to do things that are not good for the state and not good for our providers. Thank you very much.
Thank you. I don't see any questions. Pat Coda.
Sly Gatewood from Americus, Georgia, and I appreciate the opportunity to come tell you my story. And it's a sad story, and it starts with the fact that I'm from rural Georgia. I was educated mainly over here, not too far from us at Grady in the Emory program, delivered lots of babies and had a wonderful experience. Had the opportunity to see a vision for Georgia. We were at the bottom of our infant mortality rates back in the 1970s when I went into practice. There were crying needs, and we had some wonderful things come from our state support systems, our federal support systems, and we went from a very high infant mortality rate in the range of 20 to less than 10 and even further down. Along with that, there came a program. It was called Medicaid. And Medicaid helped us to move deliveries from out of the homes and into the hospitals. It brought in the opportunity to have quality care and teaching and a very different level of expertise in the way of certified nurse and midwives, not the granny midwives, which were wonderful in past years, but the certified nurse midwives. I'm an advocate for them. That's not why I'm here today. I'm here today because what I have seen is an extremely steep decline in the availability of care in rural Georgia. We have gone in Americas from 10 physicians and certified nurse midwives to 3. And for 1 week, we had no obstetric care. We're talking about a hospital where we delivered up to 1,000 babies a year. We have been recognized for a high quality of care. Just been very fortunate to be involved in that community. The sad thing is the 3 we have now are no longer in private practice. We've gone from 4 private practices employing a good many people to 3 very fine OBGYNs, young, still on their rural incentive scholarships. They'll probably be gone when that's up, because what has happened is with the situation with Medicaid, no increase in the last 8 years at all, where our office expenses have gone way up, our operating expenses are out of sight, have to hire 2 people as coders. Sad thing to me along the way is that physicians have become more inclined and having to go out and take courses on how to run your business. Now, we want to be efficient, but dadgummit, I don't want to have to sit and look at coding and all the explanations of benefits for 3 hours a week. I want to practice medicine, and there's a great need for it. As we've lost our numbers of obstetricians, we've also seen the fact that we have no other resource. Back in the 70s, we had very well-trained public health nurses who had experience with prenatal care. They're gone. We no longer have a system in rural areas. Got so concerned about all this early in this year that Pat Cota, who has helped us so much in obstetrics, sent out a survey. And our survey is very frightening. We find that 75% of our physicians in rural health obstetrics now are planning to retire in the next 10 years. The biggest problem we found in the survey, which was what I already knew because I've been doing it for the last 10 or 15 years, is trying to recruit young physicians to come to the rural areas. And it's not that the rural areas can't be sold. All I have to do is spend a day or 2 in Atlanta, and I love it. But it's not a good way to live. And we can bring people down to South Shore. It's not my preference to live. Excuse me. It's a great place to live. All around if you're a city person. But the country offers a lot. And we can get people down and sell in the country, but then I show them what I made that year. And they say, you're not really doing that. And, if they do have the scholarships, they're gone soon afterwards. So we've had some wonderful people come through. The love of my life, other than my wife, was the last associate I have. She was an MCG graduate, went through the program there, was the best resident in her class. She struggled for 7 years with me to try to stay in Americas. And after having 2 children and the responsibilities there, Beverly said, hey, I just can't do it. And with breaking my heart and her heart, she's moved to North Carolina, where they have a better program, where she's not dealing with the 80% Medicaid patients that we've been dealing with in Americas. Next door to us is Cordele. Cordele had 3 OBGYNs. When I first moved in, they had none. They're down to 1 now. And it's the same issue. We're not funding them. We've got to decide whether we think it's important to provide obstetric care and prenatal care for our citizens. 80% of our babies delivered last year were Medicaid. If you look at the survey we had, 75% of rural practices have at least 40% or higher. You just can't make a living with Medicaid. And there are no other sources. The old days, we used to take pigs and chickens and have a lot of preserves brought in, but we've lost that concept too. So we even missed that part of it. Do have documentation of the fact that we've not had raises in Medicaid in 8 years. One of the saddest things for me is just look at Americus, Georgia, or all our area where we have so many people with great needs, nutrition, health education, and see that a lot of our doctors are doing what I call boutique type medicine. They're advertising for Botox. Why do they do that? It's because that's the only way they can make enough money to take care of the poor people and the other folks that are that we really come to the rural areas to care for. Just really disappointed that we didn't get our expected raise this last year in Medicaid reimbursement. The whole concept of dropping it 6% and with the amount of millions of dollars that will add to what our burdens already is very sad. I did stop OB this year. It was very hard for me. I had been doing it for 34 years. I feel like I'm walking around naked with don't have to be on call. But my heart is hurting for what I see is happening in the rural areas of our state. The hospital's the same way. In a small environment, you're very attuned to all the needs of the hospitals. We hate to see our hospitals close up, to shut down, losing the obstetric services and having to leave and drive, for folks to drive 40, 50 miles. You can do it if you're wealthy. You can do it if you have that on and get your regular appointments. But if indeed you are, as many of our folks are, having to fight the battle of no jobs, high gas prices, tough to get care. We've almost never seen no prenatal care, but we're starting to see it again. So that's my personal story. We need your help. I've been involved with Georgia OBGYN. I think that the heart of the OBGYN organization is the entire state and the needs there, and there's certainly needs in the cities. But they're very dramatic where we are. And my personal story, and I thank you for the opportunity to present it to you.
Thank you, Doctor. I don't see any questions.
Any questions?
No, sir.
Okay. Thank you. I'm all for taxing tobacco. I wish I could tax cocaine. Okay, we see a lot of that too.
Victor Madivan. I hope that's closed.
Victor Moldovan, sir.
Moldovan. Excuse me, sir.
Thank you, Mr. Chairman. I represent Guardian Home Care. Guardian is a provider of home care services. Most, as you probably know, home care services are primarily provided to folks who are covered by either Medicare or Medicaid. Medicare probably makes up anywhere between 70 to 80% of most home care providers in the state of Georgia. The rest is made up of Medicaid. You have some private pay, and the rest are indigent, which is that they're not covered by Medicare, they're not covered by Medicaid, or they're indigent. So when you have a cut or you don't have an increase in the reimbursement rates for Medicaid, it's pretty dramatic for these type of providers. The whole point of a home care provider is to take folks who would normally be in a skilled nursing facility or in a hospital, and you treat them in the home. They get skilled nursing, physical therapy, occupational therapy, home health aides, things of that nature. So about 30 years ago, the government decided that home care was a good thing, and they've actually promoted it and said, look, let's get these folks out of the skilled nursing in the hospitals. Let's put them into their homes. They can be home. They're more comfortable. And we'll send the providers out to their homes and treat them there. It's more cost effective. It's cheaper for the government. It's better for the patient because they're in their own home. The problem, of course, is that when you don't increase Medicaid reimbursement or you cut Medicaid reimbursement, the ability of the providers to provide those services in the home declines. In fact, Medicaid today does not even cover the cost to home care providers to provide the services. They actually lose money when they provide Medicaid. They have to make it up either through some sort of private pay. They try to make it up with Medicare maybe, but for the most part, they lose money on Medicaid patients. So when they take them, and they're required to take them, if you get a CON in Georgia, as you all know, for home care, you have to provide services to Medicaid. You can't say no. So you're required to do Medicaid, but at the same time, the state says you have to take them, but we're not going to pay you the cost of those services. You're going to lose money on those patients. In addition to that, home care providers, like other providers in the state, are required to do indigent care for 3% of their adjusted gross revenue. So you've got to do 3% free, Then you've got Medicaid, which doesn't even cover your cost. And then you've got Medicare, which covers your cost maybe, and you make a little bit of money maybe, and that's what you're required to do in the state of Georgia if you're a home care provider. If you don't increase Medicaid reimbursement or you cut Medicaid reimbursement, the home care providers are going to suffer pretty dramatically, and as a result, Medicaid recipients will suffer pretty dramatically. There are a couple things that can be done, and Guardian obviously supports putting back in the money for home care. It's better for everybody. It's better for the patient. But also one of the things, and I just want to sort of tie them together, is the 3% indigent care commitment home care providers and other providers in the state have to make. As you all know, those funds that home care providers pay, the 3%, go to the Indigent Care Trust Fund, which is for the hospitals, and that's fine, but home care providers don't participate in those funds, so they're required to pay in. The money doesn't come back out to them. It goes to the hospitals. So it's counterintuitive. You want the home care providers to provide services to these folks in their homes. You want to cover them by Medicaid maybe. Even the indigent, you want to keep them in their homes. But you're taking money away from the home care providers. You're putting it into the Indigent Care Trust Fund under this 3% requirement. And you require them to do Medicaid, even though Medicaid today doesn't even cover the cost of those services. So Guardian clearly supports the Medicaid funds being put back in. We've got to have those increases. They're already delayed for a significant period of time. I would point out that in 2007, looking at just the 2007 stats, Georgia Home Health Agencies overall, not just Guardian, provided services to almost 8,000 Medicaid patients. Again, those patients, those services provided to those patients, the amount that is paid to those providers, including Guardian, doesn't cover those costs. So you've got a problem where basically you're taking away reimbursement for services that are obviously needed by those folks, and at the same time you're taking cash away from the providers because you're requiring them to do 3% of their adjusted gross revenue for indigent care. Obviously the economics don't work. It's not going to work. It's going to get worse. And so we're asking the committee, to the extent that you can, to recommend that you either put back or do both. You put back the reimbursement for Medicaid providers, or we do something about the 3% tax on home care providers that basically comes out of their pockets. I appreciate your time today. Thank you very much.
Thank you. I don't see any questions. Stan Jones.
Well, I'm Stan Jones with Nelson Mullins Law Firm. I'm here this morning to speak for Visiting Nurse Health Systems and some of the other home health providers. You have the benefit that Vic has just eloquently described what the needs of the home health agencies are. 2 years ago, the home health agencies received the first increase in 12 years in the cap on their Medicaid rate from $75 to $90. The state fund cost of restoring, not cutting that cap or restoring it for 2010 is about $1.8 million. It's a huge benefit to Medicaid beneficiaries. We believe also, as Vic has eloquently stated, that hospital care can be reduced by better home care, both in the home health situation and for CCSP. I might add as well that some of the cuts in the provider rates affect other things too. The children's agencies under DFACs of care for kids with severe mental illnesses effectively are being reduced 3% by delaying again the cut in the provider rate increases for folks like psychologists under the Medicaid rehab option. So there's also an effect in the DHR, DFACs, and mental health budgets for not restoring the provider rate increases that were originally part of the 2009 and 2010 proposals. I know that David also eloquently said that FMAP means medical assistance. Hopefully we get the math right and are able to draw down additional funds. I suggest also that with the changes in the FMAP, the benefit to the state of the CMO provider tax is also affected, at least for the short term, in the first couple of months of the new fiscal year. Thanks very much.
Senate President Pro Tem has a question.
I've not heard any of you mention the governor's proposal to on the bed tax to draw down additional federal money. Is that just off the table for most of you all?
Certainly, several of my clients hope it is. What I was talking about is the first 4 months of the 3 months of the new fiscal years, you're still going to be able to have the CMO tax at the 6% level. It's really October 1 of 2009, excuse me, when the changes in the federal law caused the CMO tax to go away unless it's broadened.
Well, given the governor's recommendation, does broaden it have any appeal now?
My client in this discussion is Kaiser Permanente, one of the health plans. The health plans would be in the boat where the additional tax on them realize no direct benefit to them. The hospitals, of course, are in the boat where the tax is a much larger than the benefit returning to them, even at the $80 million cut level.
I see no more questions.
Thank you.
Former distinguished House member Ron Dotson. There he is.
Thank you, Mr. Chairman and members of the committee. It's good to see a lot of you again. I miss you like I miss my kidney stone. So. I am Ron Dotson. I'm chairman of the board of Southern Regional Medical Center, which is a 360-bed hospital south of here in Clayton County. And Senator Williams, before you leave, I want to answer one of your questions that you asked earlier about how will this affect the profit over the cost, expenses. And in our case, it would add about $12.5 million. Well, our profits last year, you asked what was the profits last year. Our profits last year were $12.5 million less than our expenses. So we're not operating in a very good stage right now. Some of you may have read or seen on TV that we are having some financial troubles at Southern Regional Medical Center, not unlike hospitals all over the state. I think we've heard testimony that many hospitals are suffering right now, and we feel like this Medicaid cut would just be another punch in the stomach, you might say. It would bring us to our knees. We are in a reorganization period at the hospital. We see some light at the end of the tunnel, but it's going to be a long tunnel. Cash days on hands, we have already our bonds have been voided because of the numbers of days of cash on hand that we have, and we've had to work through some new financial areas to make that where we can continue to operate. Before we get all the way back out of the tunnel, we may be down to as low as 20 days cash on hand. Right now we're at about 55 days, and we were to be at 95 days cash on hand to meet the requirements of the bond issue. We have a very large Medicaid population in Clayton County, and it's increasing daily. One of the ways that the hospital was making a little profit was on Medicaid childbirth. And we have a large Hispanic population in Clayton County, and they reproduce. We were looking at maybe some survival mode through that. But if this is cut, then I'm not sure that we can afford to do that anymore, or if we do, it will be at a loss. The only ways we have left to save, we've already cut some employees back. We've cut back some in some areas of advertising and other areas. But the only way now that we see possible to cut much more in the way of expenses is to cut services. And that's something that we do not want to do. We want to provide the best health care possible in the South Metro area that we can. If we cut services, it will be a low-profit service that we'll cut, and that will just send these patients to another hospital in the area that will be picking up a low-profit hospital. This 10% cut, if that's what it's going to be, and it's hard to understand because of some of the language, would
take about another $3.5 million off the bottom line at Southern Regional Medical Center. And we've already had a loss of almost $13 million. That's quite a bit. I just want to say that I care as much about the rural hospital as I do the metro hospital. Chairman Chanel, I think you live in a county, Greene County, where y'all lost your hospital for a short time. Minnie Boswell did close. You were fortunate enough that a for-profit was able to come in, revitalize, and you now have health care. And my wife had an aunt that, because of that hospital being open last week, she was stabilized, and they were able to move her to Atlanta. So it looks like that hospital being open saved her life. That's true around the state. It's something that we need to keep the hospitals open as much as possible with good doctors, good nurses. And if Medicaid is cut to the degree that it looks like that we're talking about, I think we would see hospitals closing all over. We're not fortunate enough to have a for-profit hospital that could buy us, because the for-profits are also having their financial problems. And I think if we look at some of the big boys, even in Atlanta, they also are having some financial drains today. So I'm just pleading that y'all do your very best, stand up and do what you think's right for the people of Georgia, not what you think's right for the party or what you think's right for exposure or anything else, but what's right for the people of Georgia. That's all I'm asking. So thank you.
Thank you. We have a former distinguished representative / Senator, Mike Pollock.
Thank you, Mr. Chairman, members of the committee. For those who don't know me, I'm Mike Pollock. I'm the Executive Director of External Affairs at Memorial University Medical Center in Savannah. Memorial is kind of in a unique situation. We are currently being managed actually by a productivity consulting firm. In March of last year, we removed our CEO from office and then turned over the company actually to the hospital over to this consulting productivity group. I'm pleased to say over the 8-month period of time in 2008, we were actually able to reduce our expenses $22 million. And that was based on downsizing our job force, improving our supply chain management, and other cost reduction activities. So we've made great strides in moving that direction to be financially solvent. Yet even after reducing our costs $22 million and having some areas we've been able to increase our revenue, we'll still report an operating loss in 2008. Our operating loss in 2007 actually exceeded $50 million. So we're in a difficult financial posture already in good times. Our challenges, though, are based on, one, a combination of factors. We are one of the highest Medicaid providers in the state. We are a level 1 trauma center. And we have a very large and growing uninsured patient base. For those of you who know, of course, know the Savannah community, we have actually one of the highest uninsured population rates for health care in the state of Georgia. A lot of that is based really on the large hospitality industry that we have in place. But also over the years, we've lost a number of manufacturing jobs in the area, which were really high percentage of coverage for health care insurance. So the governor's proposal actually really impacts us in several ways. One, the 10% across Medicaid cut impacts us as well. But also, we actually have a large employed physician force, so the 6% cut on top of that impacts that as well. That overall cut is anticipating growth in our Medicaid patient population will roughly be about $7 million net loss for us based on those combination of factors in the governor's proposal. So we've gone through a period of time where we've downsized. We've eliminated over 400 jobs within Memorial over the last 18 months. We've done everything we can do. We've actually turned over to a productivity consultant. We're doing the right things a business should do to be solvent. But on top of that, to take the $7 million cut on top of that in an area where our cash on hand is barely at the level of meeting our bond covenants, Our cash on hand reduced 22% last year in 1 year. You can't keep on going down that pace in that direction for long. So, what our options are. Our options are, we're going to continue to provide excellent service to our patient base, but we're going to have to look at how do we downsize the level of services that we offer. St. Joe Candler, who's is in the community with us, they face the same similar challenges we do, so it's not really unique to us or to other hospitals in our area. So basically what we're asking today is the $1.73 billion stimulus dollars that came down. Is there a way to try to make the Medicaid cuts whole? And we know after you do that, there'll still be dollars available to disperse to other budget needs. But really a hospital like Memorial, in the situation that we're in, as Memorial and St. Joe Candler being the largest employer in coastal Georgia, we were just looking for some help just to keep us whole. Again, we're not looking for additional dollars. We know, we understand the expectation and what's going on. And believe me, I sat in your chair for a number of years, but never faced what you're facing with this economic situation. So really my prayers are with you from that sense as well. But again, I hope you'll try to make the Medicaid budget whole. I hope you'll think about us in South Georgia hospitals, rural hospitals, urban hospitals. Hospitals across the state are having significant challenges today meeting the needs and the patient needs of our community. Thank you.
Thank you. I don't see any questions. Glenn Pearson. Glenn Pearson. Brian Forlines.
Good morning. I'm Brian Forlines. I'm the reimbursement director at the Medical Center of Central Georgia in Macon. Reimbursement, my job is to try to make sure that we get all the money in we should get in from government payers, Medicare and Medicaid. First of all, I want to thank you for letting us come and speak to you today and for holding this meeting. And I also want to really thank you for your service. I know you guys always have a tough job, and this has got to be the hardest year for you. The Medical Center of Central Georgia has over 600 beds, and we're a very busy place. We stay full. We're the only level 1 trauma center from Atlanta all the way down into North Florida. A large complex hospital like ours needs a 4% operating margin. It's the only way we can really replace the equipment that we have. It's the only way we can have new technology. It's the only way we can keep and retain staff. Last year we could see this coming. We could see problems coming, and we went through a rather significant reduction in cost. We took out 7% of our cost, which was $43 million. Now, we were already pretty lean, but now we are very lean. It is tough for us right this minute. The proposed change in the Medicaid budget would reduce our bottom line by $20 million, and that's actually what we budgeted for this year. So we're now looking at a zero bottom line. And the trauma money that's now been zeroed out would actually put us into a loss. Our place had always made money before, and now we're looking at a loss. And what that really means to us is that we will not be able to add to the new technology, the new medical sciences that are out there. It will put us behind a year or two in taking care of our patients. No matter what happens, we're going to survive. Other hospitals that you've heard from, they won't make it, but we will. Our biggest problem is twofold. One is it will put us behind on being able to keep up and take care of our patients to the most modern way possible. And two is it's going to really impact the rural hospitals. Those hospitals do a really important job of taking care of patients that aren't quite as sick as the ones that we are used to taking care of. If those hospitals are closed, those folks are going to be coming to us. We won't be able to handle all the very complex patients, and it's just going to cause a continual spiral down of how we can help take care of our folks. What we're really asking for you today is for you to keep Medicaid money as Medicaid. And also we want to really thank you for your time and your consideration of this issue. Thank you.
Thank you.
Thanks, sir.
Gregory Dent.
Thank you, Mr. Chairman and committee members. I'm Greg Dent, and I serve as chair of the Council of Regional Cancer Coalitions of Georgia, and also serve as CEO of Community Health Works in Central Georgia, which is a regional center for health innovation. I'm here today to say thank you. This committee's been very supportive of regional council and the coalitions, and we appreciate that. I want to give you a brief update on some of the good work of the council, in particular the work in Central Georgia and Southwest Georgia. Central Georgia, we have a very robust mammography program, and in that program we're seeing, through the expansion of digital mammography, we're seeing an increase in abnormalities in women under 40. And some of these funds that we get from you are used to create that program and used to expand the reach of that program to help reach women that would normally not have access to mammograms. In Southwest Georgia, they use some of these funds to run a nationally recognized colorectal screening project. That project is going to be a pilot across the nation, and they use those funds for that purpose. Over this last year, we conducted an extensive evaluation of our work. It's a 67-page document. In the effort of being green, I did not bring that today, but I will send it to you electronically. It shows that the work that we've been doing in the local communities are serving the citizens of Georgia very well, and in particular serving those that are uninsured and do not have access to care. The relationship with the GCC and DCH and DHR is a good relationship now. We've continued to work on that, and we're working very closely together. The one thing I do want to mention on funding, this year our funding specifically for the coalitions was cut by 10%. And I believe some of that was because we were rolled up into an administrative line item. And I just want to clarify that to a certain extent. The programs that we conduct, the funds are not strictly used for administrative work. They're used for outreach, reaching the people, bringing them to the services that other state funds create. So next budget cycle, I would ask that you relook at where we're placed in the budget. It's a little misleading. Those funds are not administrative funds. The state does have a vision for cancer. It's the State Cancer Control Plan. So you have a vision outlined for how the state of Georgia wants to combat cancer. I would encourage you over this year and the next couple of years to make a great attempt to fund that plan, to fund that vision, and to look at that plan. Inside the Cancer Control Plan, it talks to a tobacco tax. And I would encourage you to fund the plan and seriously consider tobacco tax as one of the ways to do that. Thank you.
Thank you. I see no questions. Representative Cecily Hill.
Good morning. Thank you, Mr. Chairman and members of the committee. I come before you today with two hats on. One hat for hospitals, as I served on the hospital board in Camden County and Glenn County for about 5 years until I came up here and had to give it up. And I also have the hat on for tobacco. Having lost a husband, September was a year ago, to heart disease caused from smoking, I have a very strong feeling about that. And I feel like this could be a win-win situation for hospitals and for the smoking. I don't have to worry about my husband now, but I have two grandsons who dip, and I want to make it very expensive for them. But the money that would be collected on that tax on cigarettes would be a tremendous help for funding our hospitals and keeping us from having to charge that additional charge to them. And I support both the hospitals, and I also support Pass the Buck. Thank you for your time.
Thank you. David Ziles.
Good morning. My name is Dave Zillis, and I'm here to talk about the Independent Care Waiver Program, part of the Unlock the Waiting List. I live in Sandy Springs, and I am the parent and caregiver of a 30-year-old son, John, who was unfortunately born with a degenerative neuromuscular disease called Friedreich's ataxia. He was diagnosed at age 11 and went into a wheelchair at age 16, but continued to go and graduate from high school and go on to Auburn University, where he earned a degree in psychology in 2003, and was basically living at home with us, where we were providing his care until March of 2008, when he was able to move into a condo as a result of being on the Independent Care Waiver Program. As you all know, the Independent Care Waiver Program really is the tool under Medicaid that enables people with physical disabilities or traumatic brain injury who are at risk of going to nursing homes or hospital placement to live as independently as possible near family, friends, and their communities. It's through this program that John is able to do that, and he represents one of the more than 800 people that are on the program here in Georgia. The situation is my wife and I are both in our 60s, and our biggest fear is what happens to John should something happen to us. And I can tell you there's quite a few people within the state of Georgia that are in a similar situation, and we just cannot believe or even consider that having John go to a nursing home would be an option. We're fortunate we have two sisters, but they both have families and children of their own, and we've made a determination that that is not the right answer, that they should be burdened with his care in the future. And so we feel that these children, much like your own children, want to grow up and live where they want to be and do what they want to do, and we've been able to do that with the Independent Care Waiver. In John's case, he cannot do the things we normally take for granted. Each day it's difficult to get up, get bathed, go to the bathroom, get dressed, prepare food. And on top of that, he has a heart condition that causes significant fatigue and limits what he's able to do. Because of the Independent Care Waiver Program, John does receive aid abilities twice a day. He has somebody come in the morning, help him get up and get dressed, and then in the evening help him get bathed and get ready for bed. And as a result of living in the condo, he's got the ability to be on several committees and socialize with other people. So he, in spite of his disability and everything, is being able to live independently in a community, which is terrific. The Independent Care Waiver is a tremendous program. It improves individual lives, but it has some real problems. Currently today there's about 153 people on the waiting list, and each month that list grows. It could very well be that when June comes around, that list will be about 200 people. And because in the current budget right now there are no plans for any additional slots next year, there could be another 200 people on that waiting list. So by July or June of 2010, we could have almost 400 people on the waiting list for this very important program. We feel that there needs to be a way to fund these additional slots. The other issue that's very important, it was brought earlier up by Steve Neff, is the fact that one of the major issues is the personal care assistants that provide help for these people. They are paid $8 an hour, and they have not received an increase since 2003. There was a proposal that originally started out about 7%, was reduced last year to 3%. That was passed. It was deferred, and now it's completely removed from the current budget. And it really is very important that we take into consideration the fact that these individuals that come and take care of our loved ones have not had an increase in over several years. The one good news is gas has gone down. You know, when gas was $4 a gallon, it was even a worse situation. So at least that's one thing. So I'm here representing the 800 and some people that are currently on the program and the 153 people that are currently on the waiting list, asking you to not only support the proposed 100 slots that are currently in the budget for Money Follows the Person, which is a program to move people out of nursing homes, but in addition to ask for 630 additional independent care waiver slots, which comes from the funding that was proposed several years ago in legislature for a year-to-year funding for the program, which unfortunately over the past we've not kept up the pace. And then finally for the 3% increase for the service providers. And I handed out to you a fact sheet from the waiting list that summarizes some of the same things. So I appreciate your support and think about the people on the independent care waiver program.
Thank you. Pat Puckett.
Good morning. I am Pat Puckett with the Independent Living Council of Georgia. Independent living programs are run by and for people with disabilities, and so I'm here to talk to you about a program that you helped us with 2 years ago, and that's the Medicaid buy-in program. It needs some tweaking and some adjustment. What it basically does is it enables people that are on Social Security disability insurance to go to work and to buy into the Medicaid program. We haven't adjusted the income levels on those since we started the program back in '06. As a consequence, there are only 2 people in the state that are enrolled in the program. At a time when we really want to encourage everybody who can find a job to go to work, I think it's a very important program that we take a look at. So we appreciate your leadership on it in the past, and I would echo the words of a lot of people here about looking at alternative sources of revenue, the cigarette tax, and I know that some folks in the Senate just recently are looking at the all the revenue picture with Senate Bill 206 and the tax expenditure, tax review bill that you have. So we really appreciate your leadership on that, and I think it's a very good move. And so thank you very much for your time, and I've got information about the buy-in program.
Thank you. Martha Phillips.
Thank you, Mr. Chairman and members of the committee. I'm passing around now a history of the Medicaid dental fees, and that pretty much tells it all. If you look on page 2, you'll see that in 2001, we received our first significant increase, actually our first increase in over 15 years. And the next 10 pages talk about how many cuts we've had. Since the CMOs took over in June 2006, we've had one cut after the other. We've either had elimination of services or elimination or limitations on the number of services. One of the questions that I've had is, since the CMOs provide their product as a risk product, you know, if you sell a product and you say you're going to provide it, I'm not sure why we need to have provider cuts. It would seem that the CMOs have already guaranteed to provide that service at that fee. In the interest of time, I'll move on, but I'd like for you to think about that. The other thing that I would like to encourage you to do is draw down as much federal dollars as you possibly can. I would also encourage you to place a premium subsidy on tobacco. This is not unheard of in the business world. If you have unhealthy habits, you have to pay more premiums. We would encourage you strongly to do that. And last of all, I know that we're not going to get a fee increase, but I would encourage you strongly, please don't cut our fees. Thank you.
Larry Lanier.
Thank you, Mr. Chairman, members of the committee. I'm Larry Lanier. I'm the Director of Government Relations for the Medical Association of Georgia. Also, in the interest of time, you've got a lot of folks here, so I'll be very, very brief. I would say that we certainly do agree with the other provider groups who've testified here today, and we're in lockstep with their concerns and what they have pointed out. Excuse me. I did want to point out a couple of other issues to you, though, and I wanted this one in particular. We are looking at a crisis in Georgia healthcare right now in a physician shortage. The Senate Research Office and the Board of Physician Workforce has projected that by 2015, we're going to have a shortage of 1,500 physicians in Georgia, and by 2020, that shortage will be 2,500 physicians in Georgia. And at that point, in 2020, Georgia will be dead last of all 50 states in the per capita physician-to-patient relationship. What we need to do is find ways to bring physicians to Georgia, to keep the ones we have, and to bring physicians to Georgia. And I want to point out a few just quick facts to you. The Carl Vinson Institute of Government did a study in September of 2008 called The Economic Impact of Private Practice Physicians' Offices in Georgia. And this is what they said. Today in Georgia, each private practice physician in Georgia today supports 13 additional jobs, $641,000 in personal income for those jobs, nearly $1.5 million in total economic activity. That's each private practice physician. If you take all private practice physicians together, in 2008, they supported more than 180,000 jobs in Georgia, over $10 billion in personal income for Georgians, nearly $20 billion in total economic activity, more than $1.2 billion in state revenues, and nearly $1.5 billion in local government revenues. That's all from this study, and we can certainly get copies of this to you. If that happens, if the physician crisis, if the shortage of physicians and that crisis occurs, what's going to happen is that patients in underserved areas are going to be increasingly driven into the hospital emergency rooms to get basic health care. That's an issue we've talked about over and over again, and I don't think anybody would agree that that's a good way for Georgians to get basic health care. We think what we need to do is improve the practice environment, find ways, incentives to bring doctors to Georgia to improve that, and cutting the provider fees is not going to do that. Don't take that from MAG and from me as a criticism. The legislature has done many, many things over the years to try to improve the practice environment. You have. You've been diligent about that, and we certainly do appreciate it. We're worried about these cuts, and we understand the magnitude of the problem that you're looking at right now. We appreciate your dedication to do the right thing and to serve the state. We'll work with you any way we can as we go forward. We certainly would urge you, if you can, to resist these cuts. And I want to thank you for your time and your courtesy here this morning.
Thank you. Earl Rogers.
Good morning, Chairman Chanel, Chairman Goggins, and members of the committee. My name is Earl Rogers, and I'm with Georgia Hospital Association. I represent all the acute care hospitals in the state. It's the for-profits, the not-for-profits, the urban, and the rural. First, I want to thank you for your stewardship. Thank you for your stewardship of this important and very significant portion of the state budget. We recognize the monumental task that you have before you, and we appreciate what you're doing and what you've always done for us. The hospital community also fully recognizes the current state of the economy and understands that you are wrestling with how to deal with the $1.6 billion reduction in the revenue estimate. In the governor's March 3, 2009 letter to the chairman of the House and Senate Appropriations Committees, which I have included behind my remarks, several areas are recommended for adjustment or reduction, including hospitals, physicians, and other health care providers. Before I address that, I want to talk about the hospital tax idea. You'll remember that legislation was introduced at the early in the session that would impose a 1.6% tax on hospital revenue and health insurance companies to raise money to fill a hole in the Medicaid budget, as well as to help fund trauma care. And you also know that the hospital associations came out very strongly against that tax on hospital revenue to pay for treatment of state Medicaid patients in those hospitals. When the hospital tax and insurance company tax legislation was introduced, the governor's office provided us with a list of items that would be cut from the budget if this legislation failed. Well, the tax did not pass, and these items are indeed included in the governor's letter that I have behind my remarks. Items to be cut including $105 million for health care provider increases and the disproportionate share hospital funding, plus the $37 million in trauma care network funding. The hospital community understands this, but what we are having a tough time coming to grips with is the proposal to cut hospital reimbursements by 10%, almost $81 million, and then the physicians and other providers by approximately 6%, or $69 million, when the federal economic stimulus package designated for Georgia will provide at least $6.2 billion. Of this, Georgia's Medicaid budget was designated to receive $1.73 billion of federal medical assistance money over 27 months to help during the resources during these difficult financial times. The total amount of Medicaid dollars for 2009 was just over $500 million. For fiscal year 2010, $780 million. Fiscal year 2011, right at $400 million. But again, for 2010, which is what we're talking about today, it was $780 million was designated for Georgia. But we're recommending, the governor's letter has recommended redirecting hundreds of millions of dollars to other budget needs. It's important to remember that when you cut state Medicaid funds, the state loses the federal match. The federal economic stimulus package brought up the federal match from the current 65.05% to 71.1%, a significant amount of federal matching dollars. So Georgia stands to lose an additional $199 million for the hospital reimbursements. When this is added to the $81 million and the recommended cut, the overall effect is a very significant and devastating $280 million. So it's really more than a triple effect, more than a triple cut. As I mentioned earlier, Georgia is designated to receive $700 million, $780 in 2010. But the numbers provided to me by the governor's office indicated that only $687.4 million would actually be drawn down. Of this, the Department of Community Health is scheduled to receive $160.6 million, and almost $527 million is recommended to be redirected, and that's listed as number 7 in the governor's letter. I'll close with asking you to consider a couple of things. Since this federal money, also known, you'll hear it sometimes called FMAP, was intended for Medicaid, please, we're asking you to take $81 million out of that 527 that's recommended for redirect. Just take $81 million of it, and please restore those Medicaid cuts. Chairman Chanel and Chairman Goggins and members of the committee, on behalf of Georgia's hospitals, I respectfully ask for your favorable consideration to restore those cuts. And I want to thank you for your time, and we really appreciate y'all listening to us today.
Thank you. I see no questions. Rebecca Greener. Rebecca Greener. Joe Fleming. Joe Fleming. LaDon Toole.
Thank you, Mr. Chairman, members of the subcommittee. I'm thankful to be here today on behalf of Grady General Hospital, where I am in Cairo, Georgia, and on behalf of many other rural hospitals. Grady General is a typical rural hospital located in a county with a population of just over 25,000 people. More than a fifth of our population lives in poverty, and that number climbs to almost 30% when you look at children up to the age of 17 years of age who are living below the poverty level. Just over 31% of the population of Grady County is covered by Medicaid. Exactly half of our citizens over the age of 65 are disabled, and 23% of the remaining adult population is considered disabled. Looking specifically at Grady General, approximately 20% of our revenues currently come from the Medicaid patients. And as you know, before the governor's proposed cut, Medicaid already pays us less than the cost of providing that care. Another 19% of our patient base is uninsured currently, and that's up from 17% last fiscal year. We hear a lot of talk about hospital operating margins, and I want you to know that the hospitals are suffering in rural Georgia. For the last fiscal year, which ended September 30th, Grady General Hospital had a positive bottom line of $29,652. But keep in mind, the majority of the last fiscal year was before the economy began its serious downturn. For the first 4 months of this fiscal year, which began October 1st, Grady General Hospital's operating margin is a negative $795,000, a loss of $750,000 in the first 4 months of this fiscal year alone. Mr. Chairman, I respectfully submit that Grady General Hospital cannot sustain a tax on our net revenues, which at 1.6%, which has been stated today, would be around $400,000 additionally, and we cannot sustain the proposed Medicaid cut of 10%. If either of these things go through, I don't know how we will remain viable in many other hospitals around the state as well. Mr. Chairman, with your indulgence, I would like to briefly share comments made to me yesterday by an orthopedic surgeon who sees patients in Grady County. He's seen patients today and couldn't make the trip. But his point to me was this. Today, before these cuts, his allowable cost under Medicaid to do what a major joint replacement surgery on a patient is around $1,100. And he went to college for 13 years to be able to do that. He said that's less than you have to pay a plumber to replace a bathtub in your house today. That was the analogy that he gave me. If he has to take another 6% cut, he's going to seriously consider getting out of the Medicaid program. And that means access to health care possibly is going to go away. I went with my chief of staff yesterday, and many of the members of my medical staff, and they feel the same way. They're really afraid of their ability to be able to continue to go along with the Medicaid program if these cuts go through. I think we all know the state is facing a severe financial burden and shortfalls, and none of us want to be sitting in your shoes today, and we really appreciate your leadership and all that you do. But the fact remains that the federal stimulus package is bringing more than enough money to the Department of Community Health to cover the shortfall, $680 million in fiscal year 2010 alone. We just want to know what makes these cuts necessary. Again, Mr. Chairman, thank you for the opportunity to share my concerns.
I have a question or two. Are y'all a critical access hospital?
No, sir, we're not. We're a PPS 60-bed hospital.
60 beds. What's your annual revenue?
Our annual revenue, our net revenue, is last year was $29,000. Is what we netted last year in net revenue.
No, I'm talking about you. I'm not talking about what you netted. I'm talking about what is your gross adjusted net revenue?
For last year, I want to say around, I don't want to misquote it, but I want to say somewhere in the neighborhood of $25 million.
Okay, thank you.
Mm-hmm.
Michael Purvis.
Thank you, Mr. Chairman. My name is Michael Purvis, and I'm the administrator at Brooks County Hospital, a small rural hospital in Quitman, Georgia. I appreciate you giving providers an opportunity to come before you this morning and give our testimony. If you'd allow me, I'd like to take just a few minutes to tell you a little about the environment we operate down in South Georgia. Brooks County is a textbook example of a rural community. Industry is fairly limited, and I'm afraid that situation is about to get even worse. Brooks County is a community of just over 16,000 residents. 23% of those citizens live below the poverty level. Approximately 34.5% of Brooks County residents are covered by Medicaid. Our community hospital operates with approximately 17% Medicaid and 15% uninsured patients. Those are fairly recent numbers within this fiscal year, but I think we can expect those percentages to grow as the economy continues its decline. Unemployment goes up and more people lose their health coverage. Brooks County Hospital ended fiscal year 2008 with a bottom line of negative $648,792 on net revenues of around $12.4 million. We're very fortunate to be part of a hospital network that is funding those operating losses. Otherwise, I don't think we could keep our doors open. I'm not sure how Brooks County Hospital goes forward. If another 10% is taken out of the Medicaid program in 2010, but I am aware that this is not this committee's recommendation at this point, and I'm thankful for that. I guess my question is this. Didn't Congress just send Georgia almost $700 million to take care of the Medicaid shortfall for the coming year? And this budget proposes to use just $161 million of it for that purpose? Now, I'm just a country boy from Quitman, Georgia, and I might not be getting it right, but we're down in Quitman just trying to take care of our home folks, and our doctors are doing the same thing. Why is the governor asking us to take the big cuts when there's more than $500 million just sitting there? Where's that $500 million if it's not going to be used for Medicaid? Thank you, Mr. Chairman.
Thank you, and thank you for making the long trip. Tom Russell. New CEO at Grady, Michael Young.
Good morning. I greatly appreciate the opportunity to be allowed to speak this morning. I'm Mike Young. I'm the new president of Grady Health System. Undoubtedly, you folks have a very difficult task before you. Having served as the CEO of Grady for the past 6 months, I have some idea of difficult tasks. I'm here to ask you to restore the funds that the governor has recommended cutting from the Medicaid budget for hospitals. Medicaid is the single largest revenue source for Grady Health System. A 10% total payment reduction would be devastating to the system and our patients. Based upon what we know about the reduction, we estimate that the impact on Grady will likely be a $26 million decrease in our Medicaid reimbursement. Grady Health System, under any circumstance, cannot absorb a reduction in its rates. Not 1%, certainly not 10%. In 2007, we lost $38 million. In 2008, we reduced that to $43 million. I'm sorry, it's the other way around. We reduced in 08 to 37 or 38 million from 43. The good news and bad news at Grady is that our patient volumes are up over 7%, $40 million on an annualized basis of additional business. The bad news is only $2 million of that revenue will turn into dollars. The rest is care to people who do not have insurance, people who thought they would never use Grady except maybe for trauma. We can't survive any more additional uninsured volume and less Medicaid reimbursement. Our uncompensated care in the month of January was over $30 million alone. That is the actual cost, not the reimbursements or discount from charges. $30 million of uncompensated care last month. The governor's proposal will disrupt the healthcare delivery system considerably and reduce access to care for your constituents. Many will have no place to go, but the ER is already mentioned, and many already go there now. And by the time they get there, they will be sicker than ever. This is not just bad medicine, it's bad public policy. Over the last 6 months, we have worked tirelessly to get Grady moving in the right direction. We focused on helping our patients find medical homes instead of using the emergency department, and to change our processes and our billing processes, and we've collected more dollars than ever. We're working hard to move Grady forward and create a financially strong and viable health care system while maintaining our mission to serve the underserved. The proposed cut will undo our efforts to stabilize Grady. We have no other way to cover the additional uninsured costs that will result from this proposal. We have 10% commercial pay, 40% Medicaid, and 40% no pay. We would have to raise our prices to our commercial patients over $250,000 per inpatient visit to make this happen. The insurers would not pay it. If we receive a $26 million reduction in our Medicaid payment, our bankers will terminate our line of credit when it comes due in April. We will run out of money in June, and we will be in bankruptcy in July. We will not be able to make payroll. We will not be able to buy drugs. There is no cost-shifting opportunity for us. The draconian cuts will also have a significant impact on the medical education infrastructure at Grady. We graduate 200 residents a year, of which more than 100 stay in Georgia, and you've already heard about the challenges in physician recruitment. We cannot continue to support the current level of medical education training with substantially less reimbursement. This Medicaid cut will serve as a disincentive to providers to participate in the Medicaid program, as you just heard. This will adversely impact the Medicaid patients' access to care. I was in the ER last night at 8:15, and there was a patient there with a broken heel. We were the 6th hospital he came to. He's from an hour south of Macon, and no one would treat him because they would get nothing. He came to Grady hoping he would get something. So please restore the proposed cuts to the Medicaid program. Without the funds restored, we will lose a line of credit. We can't make payroll. There will be 70,000 monthly visits that have to go somewhere. 9,000 ER visits that will have to go somewhere every month when Grady goes down. As the other speakers have mentioned, the federal stimulus package has tremendous dollars in the FMAP stimulus package, and we respectfully ask that you allow the dollars to follow the patients, because there is no blood left in our stone. So thank you for this opportunity to speak this morning.
Mr. Young, would you elaborate a little bit more on losing your line of credit?
Correct. We have a line of credit of $40 million with Wachovia, and we live between ICTF payments, which come twice a year, once in the spring and once in the fall. And as we run negative cash flow, we go to the line of credit. Wachovia, who's holding our line of credit, is like many of the other banks currently in the United States, looking to get out of credit arrangements and not expand them. And they follow our cash flows weekly, and a $26 million cut in Medicaid, they'll just simply not renew the line of credit. So we'll get the ICTF payment this spring, we'll pay down the balance on the credit, and we have 1 day's cash on hand. So with this Medicaid cut and the reduction, by the second week of the month, we won't have enough money to make payroll.
Thank you. I see no questions.
Thank you, sir.
Lance Duke.
Well, good morning, Chairman Chanel, Chairman Goggins, and members of the committee. I'm Lance Duke. I'm the Chief Operating Officer of Columbus Regional Healthcare System in Columbus, Georgia. Of course, we want to acknowledge the extreme difficulty of the current financial situation and economic conditions, and certainly the task before you is monumental, and we thank you for your service and your hard work and your willingness to try to work on solutions. I do want to begin by just sharing an analysis of the health of hospitals nationally that was released on Monday. This analysis was conducted by Thomson Reuters. It was an analysis of 439 hospitals in the country, Gary Pickens is the Chief Research Officer for the healthcare business of Thomson Reuters. And his quote in the analysis, hospitals are facing unprecedented economic stress, and many of the indicators we are seeing suggest that things will get worse before they get better. The median total margin among those hospitals in the study was 0 for the third quarter of 2008, which is the lowest ever seen, and 50% obviously of hospitals were unprofitable during that third quarter of 2008. Translate that to hospitals, and you've heard it over and over here this morning. Hospitals cannot continue the services that we offer under this tremendous stress that we're already under, and add to that the cuts that are proposed here today. Columbus Regional Healthcare System is a 3-hospital system in Columbus with 2 nursing homes. We are the region's safety net hospital. We provide about 90% of the Medicaid care for our region. We are a trauma hospital. We are a regional perinatal center. We have a family practice residency program that is one of the oldest and the largest in the state of Georgia. In the economic stimulus package, as has been mentioned several times, approximately $1.73 billion have been designated to Georgia, specifically intended for Medicaid. The drawdown in 2010, it looks to be about $690 million, with more available, approximately $100 million more available, with the difference being the reduction in the Medicaid budget and therefore the inability to draw down federal dollars. And for every dollar the state cuts from its Medicaid program, more than 2 federal matching dollars are left on the table. Under the recommendations currently being considered, the 10% reduction in Medicaid spending for hospitals and 6% reduction in reimbursements to physicians is simply not sustainable. For Columbus Regional, with the reduction in trauma payments plus the Medicaid reduction, that amounts to about a $10 million reduction in revenue for our organization. And again, this would be devastating in terms of our ability to continue providing the depth and breadth of services that we currently offer in our community and region. Bottom line message that I would urge is to use federal funds that are intended for Medicaid to support Medicaid to ensure this program stays intact. Maximize the drawdown of federal funds, and then and only then redirect some of these funds to other state needs. And finally, since we are a trauma hospital, let me just take the opportunity before you to urge support for the fragile state of our trauma system around the state. As you know, there are only 15 trauma hospitals. We have significant areas of our state that are uncovered by trauma hospitals, more physicians choosing to not participate in trauma coverage. And so before the system collapses, please do take the opportunity to provide sustainable funding for trauma going forward. Thank you for your time this morning.
Thank you. Julie Wyndham.
Good morning, Mr. Chair, members of the committee. I'm Julie Wyndham, Vice President of the Georgia Alliance of Community Hospitals. On behalf of the state's not-for-profit hospitals, I want to thank you for the opportunity to speak with you today about our opposition to the proposed budget recommendations. We certainly recognize the tremendous crisis that the state and you as budget writers are facing. We as partners with the state are willing to do our share to help at this difficult time. That is why we, along with the other provider groups that you've heard from today, have willingly accepted the deferral of rate enhancements that you and your colleagues so graciously gave us in the 2009 FY budget. What we cannot accept is the current proposal to cut hospital provider rates that are already below cost by 10%, while at the same time diverting over $500 million to other areas of the budget and leaving an additional $120 million in federal funds in Washington. In a time of record high unemployment, our state's reliance on the Medicaid program is only going to increase. That is why we strongly encourage you not to divert federal Medicaid funds to other parts of the state budget and to pull down all available Medicaid dollars through the increased FMAP, thereby at the very least maintaining current Medicaid provider rates. Thank you, Mr. Chairman. If there are any questions, I'll be happy to answer them.
Don't see any. Thank you. Linda Lowe. Thank you. That completes the people who have signed up in advance, is there anybody in the audience that feels the need to address the committee? If you come down and identify yourself, sir.
Hi, my name is Gordon Draves. I'm president of Georgians Against Smoking Pollution, a very small nonprofit organization. We're mostly concerned about non-smokers' health from the passive smoking angle, but also I'm very concerned about the angle of how much money is being taken out of the pockets of non-smokers to fund smoking care. In Georgia, we spend out $537 million each year in Medicaid funds to treat tobacco-caused diseases. Now the thing is, if we count every cent from the tobacco taxes that come in, we would still have a $300 million deficit. They only contribute about $240 million each year in taxes. So we have a deficit of $300 million. Where do we get that? We go to the general fund, and most of those tax dollars are from non-smokers. So I hope you'll think about that when you consider legislation to increase or reimpose sales tax on food, a tax on hospitals, and those kind of things. When you can tax tobacco products and have a good income of $300 to $450 million to take into consideration that deficit between the income and the outgo for tobacco-caused diseases. A lot of you have hospitals that are county-owned hospitals. Medicaid reimbursing those hospitals at 80% is not good enough. I think that we should do something about that. We should increase the Medicaid amounts to the hospitals so that they will not go out of business. This talk about reducing it by 10%, I think, is really not economical. I think that we really need to do something better than that. So I hope you'll consider the tobacco tax. It will bring in income that is vastly needed in Georgia. It will help provide monies for these programs that are so much in decline and all of those kind of things. So I hope that you will consider the tobacco tax as a good tax, actually a user fee on people who use these products. They should be paying more. Ask the question, who should pay for tobacco-caused diseases? I believe the user of those products should be paying a lot more. They only give us $240 million a year. Well, our just for the Medicaid is $537 million. And when we put out that $537 million to the hospitals and doctors, at 80%, the doctors and hospitals are absorbing $134 million in costs to treat tobacco-caused diseases among these people. Please pass the buck. The $1 increase on the cigarette tax will bring in $300 to $450 million, and it is needed in Georgia. Thank you very much. Any questions?
No, sir, I see no questions.
Thank you.
Chair, been informed that Glenn Pearson was called on earlier and now present.
Thank you very much, Mr. Chairman, and committee members. Thank you. My name is Glenn Pearson, Executive Vice President at Georgia Hospital Association, and I'm here this morning to read a statement from Bill Moore, the CEO of Atlanta Medical Center, who is also chairing another group called Access Healthcare Coalition. So I'm speaking on his behalf today. My name is William Moore, and I'm chairman of the Access Healthcare Coalition, a diverse coalition of Georgia hospitals, physicians, businesses, local governments, nursing homes, pharmacists, and dentists. Our coalition formed 17 months ago for one purpose: to preserve access for the state's Medicaid population by advocating for fair and reasonable Medicaid payments to Georgia healthcare providers. I'm sure it's no surprise to you today that the Access Healthcare Coalition has some major concerns with the governor's proposed budget. 2 weeks ago, our coalition was filled with optimism after learning that the federal government would be sending Georgia more than $1.7 billion for its Medicaid program. From our perspective, the new dollars would not only fill the projected $208 million hole that faced Georgia Medicaid in 2010, but would go a long way to providing some desperately needed payment increases to Georgia healthcare providers. On Tuesday of this week, we learned that the vast majority of the new federal Medicaid dollars would be directed elsewhere, and that health care providers would be facing yet another massive cut in Medicaid payments. This was a devastating blow to every member of the coalition. As you deliberate these challenging budget numbers, I ask you to consider three sobering facts. First one, more than one-third of all Georgia hospitals are currently operating in the red, and many, especially those in rural areas, simply cannot absorb another massive rate decrease. Many of these hospitals have been operating with a deficit for 3, 4, 5, or even more years, and our question is, how long can they continue? Presently, Georgia hospitals are paid about 84% of their costs for treating Medicaid inpatients, while hospitals and other providers haven't had a Medicaid rate increase in 7 years. If this proposed budget passes, this could be the death knell for several Georgia hospitals, some of which serve your own constituents. Number two, Georgia physicians are currently paid 30% less for treating Georgia Medicaid patients compared to what the federal government pays for similar care for Medicare patients. With that said, many simply cannot afford to continue treating this vulnerable population and have made the very difficult decision to stop seeing Medicaid patients. Other healthcare providers such as nursing homes, dentists, and pharmacists are in similar predicaments. If this proposed budget passes, this will make a bad problem much worse, threatening access to health care services to hundreds of thousands of Georgians, including children. And finally, number three, when the state of Georgia fails to pay adequate Medicaid rates to Georgia health care providers, it's a hidden tax on everyone else, especially the Georgia business community. And that's why they're part of the coalition. A recent study conducted by Milliman researchers concluded that this hidden tax adds about 11% to the premiums of those with commercial health care insurance. The passage of this proposed budget would continue this dangerous cost-shifting cycle and result in skyrocketing health care costs for Georgia businesses while placing a massive burden on local governments. We can ill afford to keep passing the buck onto Georgia's business community. In summary, the Access Healthcare Coalition understands the unprecedented budgetary challenges that faces our great state, and we recognize that everyone has to share in the pain that comes with balancing this budget. But as the CEO of Atlanta Medical Center, I can speak with confidence that our state's healthcare infrastructure has already been cut to the bone. Another massive cut to Medicaid will push many Georgia healthcare providers over the edge. The Access Healthcare Coalition respectfully asks state lawmakers to use the new federal Medicaid dollars to prevent these proposed cuts. If you would like to learn more about Access Healthcare Coalition, including the list of organizations, please see the two-page color flyer that I'll hand out right now. Thank you very much. Any questions?
No questions, sir. Thank you. Yes, sir.
I'm Sam Grossman, Mr. Chairman and committee members. I'm Director of Government Relations for Pediatrics Medical Group. We're a national medical group that provides neonatology services in 31 other states. Georgia is one of the states where we provide these services. Neonatology is a specialized pediatrician that takes care of premature, critically ill newborns. Oftentimes end up in our neonatal intensive care units. In Georgia, we provide these services in Atlanta, Augusta, Macon, and Savannah. And before I go on, I certainly would like to thank both you, Senator Goggins, and you, Representative Chanel, and your staff. I've worked closely with David Bain and Margie Goggins in the 09 budget, and we appreciate your work there. We do have an outstanding issue that we got a letter yesterday from the Department of Community Health that we're going to seek your help on regarding some renumbered CPT codes. I get to do this in 31 other states, and all of the other states that have experienced these renumbered codes have applied them as a one-for-one match except Georgia, and for some reason we are unable to get the Department of Community Health to work with us on that matter. Like most of the other physician provider groups that have testified today, we are in lockstep, 100% support, echoing their comments. We do believe, and I know the distinguished colleague from CHOA, David Tatum, mentioned that the FMAP money needs the medical assistance needs to be there for Medicaid, and so we strongly urge you to restore these cuts. With that, I want to thank you again for your support, and we're going to look forward to working with you as we go forward in fiscal year 10. Any questions I may be able to answer, I'm more than happy to take them. Thank you.
Thank you. We will be having a meeting on Monday, public meeting that I think it's Monday at 3 o'clock with the department, and this particular issue that you brought forth, we will certainly be inquiring as to the status of that. Is there anybody else?
Mr. Chairman, Joe Fleming with the Georgia Chamber of Commerce. I apologize. I had several conflicting hearings this morning, but we just want to add our concern and disappointment in the proposed cuts for Medicaid. We've been an active and enthusiastic partner with the Access Coalition. This issue, Medicaid reimbursement, is an issue of fairness. Healthcare providers are being provided 84 cents on the dollar today. It was scheduled to increase last year. This will take it back to about 75, 78 cents on the dollar. But more importantly, many of these healthcare providers are at the very core of the business community throughout our state. And we're deeply concerned that these kinds of cuts would have a harmful impact on our ability to attract new business to Georgia and communities outside of the Atlanta area. Appreciate the committee's concern, and just briefly wanted to add our concerns and our willingness to work with the committee on other ways to restore the money that's desperately needed here, and to make certain that the $780 million that's being sent to Georgia that's supposed to be dedicated for Medicaid goes for that purpose. Thank you, Mr. Chairman. Thank you, Mr. Chairman.
Chairman Goggins has a question.
Joe, how you doing? Thank you very much. First of all, I want to thank you and also all involved with the Access Coalition for going to bat for me, speaking to our leadership on the Senate Resolution 277
yes,
for the trauma care, so thank you for that. Let me ask you this question. What kind of support do you think we would garner if we didn't do the hospital but looked at maintaining the CMO quality assessment fee at 3 and doing the private insurance at 3, staying away from hospitals? Obviously, that's somebody else has got to pay, and I know both sides of the story of, they would say they're going to raise the fees and pass it on to consumers.
Dr. Goggins, it's an issue we've looked at because that was in the initial proposed legislation filed in the House. My answer may be a very simplistic one. It seems like the money that's coming from Washington, D.C., which is intended for Medicaid, is sufficient to at least keep us where we are, holding steady today. We have opposed the hospital tax, patient tax, bed tax, whatever you wish to call it. We also opposed the tax on the HMOs. Frankly, the federal regulation was intended to discourage the taxes on HMOs and discourage states from taxing CMOs. That 3%, 5%, whatever additional cost on HMOs will go directly into the healthcare costs being borne by businesses today, and we believe, unfortunately, will have to be passed on to employees, adding to the cost and further exacerbating the problem we have today, which is more folks on the rolls of the state health insurance plans and on the rolls of the uninsured. So I realize that there are tough choices that have to be made in these very, very difficult times. Unprecedented foreclosures, unemployment, stock market's not been doing very well lately. Everyone's hurting, so I understand it's going to have to be sacrificed by everyone. But again, it seems to me if we stay true to the intent of the money that's being sent down, then we've got enough to do that. But I think as a matter of public policy, it's a bad idea to add additional costs to private market employer-provided health care plans that ultimately are going to probably produce more uninsured and add to the cost of health insurance.
Thank you.
Yes, sir.
Is anybody else? If not, I'd like to personally thank my co-chair, Senator Goggins, and members of the Senate, as well as members of the House Committee, for taking this time to have this public hearing. I think it's a very efficient way to do a public hearing with both bodies hearing the same thing at the same time. It prevents a lot of you guys from having to come here twice to do the same thing. So again, thank the members of the committee, and thanks to everyone who has made the effort, and a lot of you have traveled a long distance to come here. We have a daunting task in front of us, and you can know that we'll do the best we can with the tools we got. Senator Goggins, do you have anything else?
Well said, Mr. Chairman.
We stand adjourned. Thank you.